Hello, everybody. We're just going to give it one more minute while we see a lot of people are starting to uh, get into the session. So we'll just wait a few seconds. We'll start at about 12:01. All right, great. Well, we still have people logging in, but I'll just go ahead and get us kicked off because we have an hour. We want to make sure that we use it as best we can. So my name is Amanda Forys. I'm the managing partner here at Magnolia Market Access, and I'm joined by three members of our team that we are so excited to have present. I'm Tracy Baroni Allmon, Rebecca Roman, and Jessica Duchen. And today we're going to talk about a pretty hot topic. And the goal of this conversation today is not to be political at all. We're not here to talk about if you love Donald Trump's administration or not, if you want to see DEI data up or jobs saved and protected in that area. We're not here for any political discussion. What we're here to do today is talk about just the straight effect of what it means when data that's important for the policy work that a lot of us do, or in market access or in health economics, if that data is to disappear and what that means into the market and the impact of that data for the pharmaceutical and device industry. So that's the goal today. We will take questions. You're able to submit questions if you have them, and we can ask them throughout the webinar, or we can just wait till the end. We'll see as they come in. So don't hesitate. Don't be shy. But I can't iterate enough how apolitical I would like this discussion to be. I'm in Washington, D.C. This week for work, and it's a very hot area right now. People are definitely feeling pressure and kind of wondering what's next, and that's really what we're trying to pull together with this discussion. So without further ado, I will hand it over to Tracy. Thanks, Tracy.
Thank you, Amanda. If we can go to the next slide. Our agenda today is, first, we're going to talk a little bit about where DEI came from, how it's evolved over the last several decades, actually, and what the executive orders, a couple of them, say specifically. And then we're going to move to DEI and commercial payers, and also talk about how manufacturers are involved in DEI, whether it's voluntary initiatives or required. The impact of DEI removal on the industry, which is really something that I think we've yet to see the conclusion of, but we know we're seeing the start of it. And so Jessica's going to walk us through that. And then Amanda will moderate a discussion that will include questions that she has created, but also ones that we will get from you as well. So thanks again, and we will move to the next slide and jump right in. Yeah. So as we think about the evolution of DEI, I think that regardless of your politics, most of us agree that this is something, the Trump 2.0 administration is something that we've never really seen in the US for the first 30 or 40 days. And so under the backdrop of that unique situation, we thought the results of a recent Pew Report survey were worth recognizing. And the graph shows public opinion of certain government agencies as of August of 2024. And so if you look, rather amusingly, the long-suffering and independent, by the way, Postal Service fares better than any of the other agencies shown, including the CDC and HHS, which are, of course, important agencies to many of us on the call. Also, according to a different survey that was conducted in August of 2024, some 15% of respondents said they have a great deal of trust in the health recommendations coming from the FDA. And in general, in that survey, a majority of respondents had some amount of trust in the FDA. And so while the measurement methods were different between that survey and the Pew survey, it's noteworthy that the FDA does seem supportive of the FDA. So if we go to the next slide, we can jump into diversity, equity, inclusion timeline. If we start before the timeline on the slide, the National Health Survey was conducted by the U.S. Public Health Service in 1935 and 1936. So as far back as then, people were looking at the underlying social and economic factors that affect health. If we fast forward to 1946, the Hill-Burton Act was passed during the Truman administration post-World War II. This bill funded the construction of hospitals, prohibited discrimination of medical services on the basis of race, religion, or national origin. It required hospitals to provide a reasonable volume of charity care and also allowed for separate but equal facilities. The Forand bill was introduced in the House in 1956 to provide social health insurance for Social Security beneficiaries. It failed and was reintroduced in 1959. Meanwhile, in 1957, the AMA continued to oppose national health insurance. As employer-based coverage grew, private plans began to set premiums based on experiences with various health costs and patient populations. Those individuals who were required or who were living with a disability found it harder to get affordable coverage. Enter the King-Anderson bill, introducing a government health insurance program for the elderly, which drew support from organized labor and intense opposition again from the AMA and commercial health insurance carriers. President Kennedy, of course, addressed the nation in 1962 on the topic of Medicare, and Johnson continued to advocate for Medicare when he became president. In 1965, a year after passing the Civil Rights Act, Medicare and Medicaid programs were incorporated into the Social Security Act and signed into law by President Johnson. The bill had massive public approval, the support of hospital and insurance industries, and no government cost controls or physician fee schedules within it. Also in 1965, the Office of Economic Opportunity established neighborhood health centers, which were the precursors to federally qualified health centers, FQHCs, to provide health and social services to poor and medically underserved communities. That catches us up to the start of our timeline, which shows how evolved and new federal agencies and departments have recognized the need for health equity initiatives since the 60s and 70s through today. Our timeline is illustrative of US agency actions and not exhaustive. It's interesting to note that following the NIH creation of the Office of Minority Health, FDA created an office with the same name 20 years later. But as we know, just because there is not an official committee does not mean the work is not being done. Yet the creation of an official committee or group requires reports, projects, and ideally sharing of outcomes. So we've definitely been moving in the right direction to not only recognize patient needs, but also evaluate whether the actions being taken are appropriately and steadily addressing those needs. And actually, in addition to what's on the chart, CDC's Global Health Equity Strategy was published in 2022 and commits the agency for the first time to advance health equity through a comprehensive approach. So that brings us up to date on DEI. If we go to the next slide, we can talk a little bit about executive orders. President Trump has issued over 200 executive orders during his second term. Because many of the actions potentially impact the creation, publication, and use of health equity information, we want to review the executive orders as an instrument to create policy change. So what's an executive order? Schoolhouse Rock, for those of you who remember it, taught us about bills and legislation in the 1970s. And there's a Saturday Night Live skit, which I found on YouTube from 2015 about executive orders, and it is pretty funny. However, I hope to be a little bit more informative today. For anybody who doesn't know, executive orders are directives that the president writes to officials within the executive branch requiring them to take or stop some action related to policy or management. They're numbered, published in the Federal Register, and they cite the authority by which the president is making the order and require the Office of Management and Budget, or OMB, to issue budgetary impact analyses for each order. Presidential memoranda and notices are other tools that may include instructions directed at executive officials, but they are neither numbered nor have the same publication requirements. The OMB is also not required to issue a budgetary impact statement on the subject of memos or notices. Unlike statutes, executive orders are derived solely from one branch of the government, the executive branch, not surprisingly, with the power granted to the head of that branch by Article 2 of the Constitution. The U.S. Supreme Court has held that all executive orders from the President of the United States must be supported by the Constitution, whether from a clause granting specific power or by Congress delegating power to the executive branch. Attempts to block such orders have been successful at times when such orders either exceeded the authority of the President or could be better handled through legislation. Executive orders cannot violate the Constitution, override existing laws passed by Congress, or infringe on the powers reserved to other branches of government. However, executive orders can be challenged in court if they're unconstitutional or exceed presidential authority, be overturned by Congress through legislation, be revoked or modified by a future president. Next slide, please. Here's just a few of the executive orders signed by President Trump that impact certain agencies that we all deal with on probably a daily basis. The impact of the policies ranges from budgetary to hiring responsibilities to the fundamental actions of the health agencies. Additionally, President Trump has also issued memoranda addressing hiring and termination of employment, publication of reports, and budget related to these agencies. These affect those as well. Next slide, please. Before moving to the discussion of payer activities around DEI and the impact of the executive orders, or EOs, on research and data collection, we wanted to share the specifics of a couple of the executive orders impacting diverse patient populations. Executive Order 14168 is titled Defending Women from Gender Ideology Extremism and Restoring Biological Truth to the Federal Government. Much of the impact from this order will be on the transgender community and those with HIV or at risk of HIV. The latest results show that 7.6% of US adults now align themselves with the LGBTQ+ community, up from 3.5% in 2012, when Gallup started collecting this data. That's almost 26 million people who are LGBTQ+, and about 1% of the country's adult population, or 2.6 million people, identifying as transgender. Additionally impacted, 1.2 million people in the US are estimated to have HIV, with about 13% being untested and undiagnosed. Estimated new HIV infections decreased 12% from 2018 to 2022, due in no small part to the work of the CDC and other government and non-government organizations that operate programs focused on education, diagnosis, and treatment, as well as trends in occurrence and spread. The LGBTQ+ experience worse physical health compared to heterosexual and non-transgender counterparts, according to a Kaiser Family Foundation brief in 2018. As a result of the order and released memos, government organizations removed or modified over 8,000 web pages and approximately 3,000 data sets. The changes primarily affected content related to diversity, equity, inclusion initiatives, gender identity, public health research, environmental policy, HIV care and policy, and various social programs. Major affected agencies, including the Centers for Disease Control, which saw over 3,000 pages altered or removed, and the Census Bureau, which removed about 3,000 pages of research materials. While some content was later restored, the modifications represented significant changes to federal government data accessibility and sparked legal challenges from healthcare advocacy groups. Next slide, please. The one other order that we'll look at in a little bit of detail is 14151, Ending Radical and Wasteful Government DEI Programs and Preferencing. This order requires, among other things, federal agencies to terminate all equity-related government contracts and grants and terminate all illegal DEI activities in the federal government. In response to this order and others, OMB issued a memorandum temporarily pausing all agency grant, loan, and other financial assistance programs effective January 28th. On Friday, February 21st, a federal judge issued a preliminary injunction blocking significant portions of Executive Order 14151 and also 14173. Under the preliminary injunction, the only remaining provision of the executive order we see here in place includes the provisions authorizing the Attorney General to prepare reports or conduct limited investigation. The termination provision, the certification provision, and the enforcement threat provisions are no longer enforceable. It is expected that the Trump administration will challenge this ruling at the district court level and likely in further appellate proceedings. In the meantime, the preliminary injunction provides temporary reprieve regarding anti-DEI efforts that were included in this executive order. Now that we have a little bit of an understanding of the pressure being placed on health agencies related to prior and new work on DEI, let's move on to gain a better understanding of DEI activities ongoing within commercial payers and manufacturers. Becky?
Tracy, oh, before we hop over to that, we had a question come in that I think now is a great time to answer.
Sure.
So, and sorry, hopefully my internet's okay here. We had someone ask us, says, it's clear that the current administration doesn't like the terminology DEI. Could we create new terminology to address health equity? I'll turn that over to you guys. I will say SDOH is the other one you hear a lot of, looking at social determinants of health, and that's been a very big term. And I think as you see today, what we're going to talk about in this webinar, we're looking at the fact that it's attacking DEI, but then it's actually affecting the research on the SDOH and what that can mean from an outcomes perspective. So it's like, if those become the dirty words, like what do we do to rename this?
Right.
So just curious if you have a thought on that from a policy perspective before we jump into like how payers are using this.
It's really a good question. I think your point, Amanda, about SDOH being other terminology, and it might also be a lightning rod of sorts. I think we don't know. I wonder if really the thinking isn't around just general inclusiveness. And you still have that word, but you don't have diversity and equity. And that is, I think, some of the trigger. I think a concern I would have about trying to create a new term is, does everybody who needs to understand the term understand it enough that the work will still get done to the extent it should be done, while we act like it might be some other type of work, right? So as not to trigger the knee-jerk anti-DEI reaction. Do employers, do health plans, do researchers understand what the new term is and how it relates to DEI, even if it's not an exact crosswalk between DEI and that new term? We may need to be a little bit creative, though, because as we're going to hear from Becky and Jessica, there are a lot of things that are out there that are making a difference and could certainly, be built upon rather than cut back and stopped.
Sounds good. Yeah, so I'll take some time to discuss various efforts and the impacts of what we'll kind of broadly call DEI within commercial payers. And as many may be aware, about 50% of Americans have health insurance coverage today through an employer. And there's really this growing recognition of the important role that employers as plan sponsors of health insurance can play in addressing health disparities. So with about, back in 2023, there was a survey conducted by Mercer, who's a health benefits consultant, and they found that 28% of employers are taking actions to improve health equity for their employees. I think employers are recognizing that healthy employees and families equal, more productive employees. But there's increased acknowledgement that significant barriers to equitable access for their employees and dependents kind of revolve around cost of benefits as well as the complexity of healthcare. So understanding really how to access or utilize their benefits. So as plan sponsors have this increased focus on equitable benefit provision for their employees, payers are also addressing this. So on this slide here, we have an example of pharmacy benefit manager goals related to health equity that were developed by PCMA, their trade association. And the goals are on these 4 boxes here, and they include addressing disparities in access, disease burden, and outcomes, looking at more equitable and affordable benefit design, promoting a culture of person-centered care, and then finally around data, investing in meaningful data, evidence, and measurement. So in addition to responding to the needs of plan sponsors, payers are also recognizing that addressing health disparities and promoting more inclusive and equitable care can lead to better clinical outcomes. And it's well established that better clinical outcomes can lead to lower healthcare costs. So on this slide, we have displayed numerous payer efforts that are ongoing. And we won't discuss each of these in detail, but the AHIP has a website dedicated to health equity that really details a lot of specific payer programs related to these activities. So payers are really using a variety of approaches to address DEI in health. They're providing specific health-related services targeting disparities. They're partnering with community organizations to increase access to care. And then they're also addressing those SDOH or social factors, so such as food and security, that can really have a profound impact on health outcomes. While it's not detailed on this particular slides, I just want to call out that payers are also using their data to provide their plan sponsors health equity reports. And a specific example published on this is Aetna, where they are assigning each of their members or beneficiaries a social risk score, and then they track their health plan's performance to understand how these social risk factors are impacting their employees. And they put this data into reports that they provide to the plan sponsors. And presumably then the plan sponsor can use that information to make changes in their plan design or potentially implement different programs to help support their employees. We also want to note that manufacturers are playing a role in advancing health equity through a variety of DEI initiatives. Some efforts are very similar to payers and how and include how they are engaging with patients, how they're looking to effectively use the data that they have, and increasing transparency and accountability around various DEI-related activities. Manufacturers are also making clinical trials more accessible through use of digital health and other technology, and increasing their focus on culturally appropriate partnerships. Similar to payers, they are broadening their mindset overall to address communities, priorities, and interests. So I'll pause there, see if there's any questions that I can address.
Yeah, I had one come in. Are any of the payers publishing this type of information? And then I guess I'll add the question to it as well as, could you see that changing if we're not seeing as much coming out publicly from other sources?
Yeah, so I should call out, I think that, regarding publishing the data, I think that the payer appetite varies pretty significantly across various payers in terms of how much and how often they report that type of information. It's possible that, that there may not be as much in the future, hopefully not. I think just like trying to continue to promote the different initiatives that they do, as well as some of the impacts that they're having in local communities could really be impactful. And it doesn't necessarily have to be published in a formal paper, things like just press releases, other types of informal media to promote their initiatives and results would be, I think, really beneficial to continuing to, do some of the work that they're doing and making that more available to hopefully help change some public perception on this type of activity.
Great, thank you.
All right. Well, with that, if there's no further questions right now, I'll go on ahead and pass it over to Jessica.
Great, thank you. So recent restrictions and changes to the collection of DEI-related data, which we're really talking about like race, gender identity, and disability or ability status, have the potential for significant impacts across our industry, particularly when it relates to health services research. So if we could go to the next slide. So here are just a couple of the impacts that we've started to see in health services research. And just to note, that this time is very much in flex, and these were things that were removed and then have been put back, and now they're put back with like caveats about, gender and where it reflects the administration, and some things have been put back with data removed from it. So just a note that some of these things reflect data that is currently available, but that we expect will one day no longer be available. So we're just in this a bit of a liminal space. And some of the impacts we should consider are clinical trials and patient outcomes. So as we know, historically, clinical trials lack diverse representation, meaning that results, especially historically, have not been fully representative of the entire population. And while there has been progress in enrolling more underrepresented populations, removing that focus by removing the FDA guidance on clinical trial diversity can further this disparity and make results less generalizable. And what this means is that medications and treatments may only be proven effective for a certain subset of the population, and meaning that they could be less effective or harmful for other sections of the population, and we won't really be capturing that data or understanding, how a treatment might work for a different group. Additionally, a lack of diversity in clinical trials means that certain populations may not have access to promising new treatments or therapies that are proven effective in trials that do not include them. So if we don't focus on sharing, new life-saving treatments or new clinical trials with traditionally marginalized groups, they might not have access to those treatments at all, which could, perpetuate this cycle of inequity in healthcare, but also mean that we won't be collecting the data that we need to show that, treatments are effective for a broad swath of the population. And this ultimately leads to the possibility of misleading safety or efficacy data. Again, without diverse representation, clinical trials may fail to account for variations in how different populations may metabolize drugs or respond to treatments, which could hold up FDA approvals, or, if we don't know that a treatment is generalizable to a whole population, we may not be able to treat the whole population. And then thinking about the removal of publicly available data, that further limits our ability to monitor and track diseases, possibly delaying interventions. And this loss ultimately impedes our ability to monitor health trends, identify disparities, and then develop targeted interventions for potentially marginalized groups who don't have access to treatment. And we may not even really be able to monitor uptake of treatments within, specific groups if we're not capturing data on race or gender or ability status. A couple weeks ago, CMS, the Center for Medicare and Medicaid Innovation, announced that they will no longer collect data from its payment model on participants' race, ethnicity, sexual orientation, gender identity, or preferred language, which introduces, potential for big holes again in how we collect and monitor diseases and, treatment uptake in specific populations. And even how, if we don't know preferred language, how we develop education materials or, treatment guidelines for patients who might be using that drug if we don't know, the language that they would prefer to communicate in. Recently, the US Census Bureau announced that they were no longer compiling statistics on gender identity. And while that's limited to gender identity for now, we know that this, DEI initiative also includes things like race and ability status. So this leads to the possibility that some of those other factors that are included in census data and American Community Service data and other publicly funded survey-based data sources that we all use quite a bit will no longer be captured. And that, again, limits our ability to understand, the underlying population, both within the United States and then in areas where we're monitoring disease trends or, treatment trends, and has a huge potential to impact policy. As many of these questions were added, when we think about the timeline that Tracy presented in the 70s, 80s, and 90s to track and monitor progress for bills like the Civil Rights Act, the Violence Against Women Act, and Hate Crime Prevention Acts. And again, leaves questions about these other, DEI focus areas for the administration.
Jessica, before you move on, quick question for you. So what happens, and I know some of this, and we've seen the administration come out pretty strong in the first month, and then some things have been kind of walked back and forth, or we've seen federal judges turn things over, or even, there's been staff eliminations within the agency, and then people are already like being reinstated or rehired. So we're seeing just some of that back and forth. I know we talked about this the other day. I just thought we might want to raise this point is, even if you see a single administration come in and take away data, but then it eventually comes back, you're now going to have a huge gap for any type of like retrospective claim studies you might want to do or anything that you would want to be able to follow over time. So that's going to create like a nightmare for people like you that are analyzing data. Curious if you could talk a little bit about that. And if that is the case, and we do continue seeing these types of things disappearing, Becky, Jessica, and this question came in from somebody else as well, like who would collect it? Like, would we start seeing the manufacturers having a whole new burden of collection? Are payers going to have to start asking for that data from the manufacturers? Are the manufacturers going to be seeking that from the plans? Like how is this all going to end up filling in that hole if it's still there?
Totally. I think, I think of it in kind of like, now when we're in 2025 and we're doing our retrospective studies, we have these COVID years like 2020 and 2021, where we almost have to not exclude those years, but really make sure we're placing those years into context because we see just crazy stuff happening. And if for, the next X number of years, we're missing data or, just it's not there or not reliable, it's going to make comparisons and understanding what happens in the future very difficult. Are we seeing our surges that we see in 10 years true surges in a specific population, or is it just that we don't know what was happening, that time period X is a huge black box and we don't know, are we really seeing an uptick of disease, or is it just that that's been occurring for a while and we were unable to capture it? It just leaves a lot of questions. And then I'll let Becky speak to that data collection piece, but I think, if this data does become harder and harder to get, going to alternative data sources, whether, it is payers or manufacturers collecting that data themselves, if they know it's, of critical interest to them, or partnering with, community organizations or healthcare organizations that are collecting this data as part of their EMRs or systems that they already have in place, and then changing those systems is more difficult than it's worth. Looking for sort of alternative data sources will be pretty critical.
Kind of like how COVID, the years of COVID, you any study you do has a huge asterisk on it, right? Like we can't tell you really if this was an effect of the disease or the fact that this person couldn't get into a doctor because the practices were all closed, or the person couldn't get an MRI because they couldn't get into a facility. Great. Yeah, Becky, curious to hear your thoughts.
Yeah, sure. So, I mean, I think as, Jessica kind of alluded to, we're all still trying to figure out what are all the impacts going to be on data collection, as well as any specific programs that we have aimed at health equity, in particular for private payers that provide Medicare Advantage or Part D prescription drug plans. If they're continued to be viewed as a federally contracted entity, then their ability to collect data could obviously be significantly impacted depending on how things play out. I think for commercial payers, from what I can tell so far, they should still be able to continue collecting data. How willing they will be to with like sharing that data or making it available is kind of I think a question mark still at this point in time. Just in terms of like how they use that data, just calling out that I haven't seen any public statements from any of the major payers really indicating any change or rollback on any of their focus on health equity initiatives. They do continue to have active like websites, highlighting their initiatives, highlighting their programs, calling out what they do in this particular space. So, I guess time will tell at this point, but it seems like commercial payers are, still going to at least now be able to continue collecting that data in their program and continuing their programs.
Thanks. And I've had a couple other questions come in. I will get back to letting you finish your slides, Jessica, but I think these are perfectly timed. So all these things coming out, we create this black box. Now, Tracy, we have the Inflation Reduction Act, which wants people to submit data on not using a QALY, but the cost effectiveness effectively of drugs for the Medicare population to establish a drug price for DPNP. So how does that happen when now you want pharma companies to put out data and publish data on a Medicare population, potentially an underserved Medicare population, low income subsidy? How does this tie into the IRA? And now if that data is not available, how can pharma companies start coming up with the studies to justify the value of their product or to push for DPNP? Do you think this would really affect drug negotiation and we could see those future prices being lower because the data won't be available?
Far be it from me to tell manufacturers how to conduct their post-approval research, but the Trump administration will be 4 years. And since everybody knows that DEI has brought a lot of good insights with it over the past several decades, I think you keep collecting it and just don't share it in that form, right? I mean, for Medicare, and I've been involved with companies in the past where if your clinical trial doesn't include many people over 65, are you going to not get approval for a Medicare indication, predominantly Medicare indication? And it never happened that I know of. And yet we know that you should be trying to get the people who will be those using the drug. The same thing would go for the Black population, the Hispanic population, other minorities. If you expect minority populations to be using the drug, they should still be part of your, not just your clinical trial, to Jess's point, but also to, your follow-up, your post-approval research. And you can slice and dice that data for submission for price negotiations any way you want. So certainly in a way that's honest and straightforward, but you don't have to break out all of those populations. But knowing that might still be really important to physician prescribers, right? I mean, if you're depending on the area of the country you're in, there are certain providers who are going to see more of a certain type of minority or some type of a diversity. And so having that data, to me, still makes sense.
Thank you. All right, Jessica, I will let you go. You can tell this is a very hot topic. I've got a
Yeah.
lot of questions coming in, so I will keep going. But yeah, I think people, like I said, it's not a political issue. Like we're laying out so many of the challenges that this is just going to create in our industry, no matter how you feel about the administration. So it's good to hear people asking like great questions coming in. I've got a couple more that I'll get to. So go ahead.
Yeah, no, just to wrap up, I think, as we've been talking about, like, this really raises the question of how will, things be measured and, calling them equity measures, like how will we measure equity measures like Healthy People 2030 and, further initiatives, but just in general, how will we measure health care access if we don't have, very basic information? And I just wanted to highlight two sort of factors that are kind of underlying both of these is the first is that if we remove, clinical trial diversity guidelines or some of these data collection fields, we're potentially continuing to undermine public trust, which we saw in Tracy's earlier slide, which is just an important consideration when we think about medical mistrust and how that is much higher, in certain marginalized communities, and something that, is beneficial to all of us to address to, increase uptake of treatments that we know are going to make people healthier. And the second and final and, perhaps the most impactful are the economic consequences. A 2023 study estimated that racial and ethnic health disparities cost the US economy $451 billion in 2018. Removal of, DEI data about race, gender, ethnicity, and ability status can continue to impede efforts to address these health disparities and can cost the US economy even more money. And when we think about clinical trials, by not conducting inclusive clinical trials, we're potentially excluding a big segment of the population, leading to ineffective treatment options, which again contribute to increased healthcare costs, increased treatments, hospitalizations, and things like that. So by failing to address health inequities, we're potentially, leaving a lot of money on the table. And yeah, next. Oh.
Neat. So yeah, we've got time for Q&A. I'm going to ask a couple questions that came in while we've been talking, and please do not be shy. And it's funny, as we were putting this together, we were like, everything we were seeing, like stuff's being pulled, stuff's back up, stuff's being pulled. So it's a lot of back and forth. So we're really curious to hear people's thoughts or opinions in terms of how this could affect their business, the way that they're planning around that, what they're doing. So this question came in, it said, could the publicly available data sources be used to target certain communities in terms of restricting healthcare resource allocation? I find that interesting, almost like a flip side of it. And curious if you guys have thoughts on that. Thank you for that question.
My thoughts, although I'll share with the group are, I suppose anything is possible, but I would imagine that would, face legal challenges based on discrimination and the like.
Yeah, yeah. I think data could be used in some ways. Like I know that they look at certain data in terms of federal contracting. I know Tracy, you've mentioned that, like how data can be allocated or looked at from those perspectives. But yeah, I don't see from a healthcare resource utilization that they would take away from places, potentially consider adding. I don't think the payer community is looking in that way either. I don't know, Becky, if you have a comment on that.
Yeah, I would agree. I don't think it's about restricting care and access. It's more about potentially developing targeted interventions for specific populations. So I think it's more that angle as opposed to restricting care.
I guess I would just add a slightly different perspective that might be a result that just occurs, right? The de facto result is that the investment and the allocation is not there because you don't have the data, not as a direct impact of not having the data, but more of an indirect, how do the trends in allocation change without that data? So I don't think it's a direct, but maybe perhaps an unintended consequence. I don't know that unintended is the right word, but not directly from the lack of data.
Okay, great. Another question that came in is about clinical trials. So if a manufacturer's kind of far down the road, they've got a clinical trial, they've been really focused on diversity and inclusion as part of that. What is this going to do in terms of changing their like application in their PDUFA review? What's the FDA going to look at? Could it help or hurt them? Should they just continue like the path followed? Like what's next steps for manufacturers that have been really building that in their processes?
I mean, if it's far down the road, I think you have to continue. So much of this, I think, is going to depend on who the FDA reviewers are and how they're looking at their responsibilities. The guidance was pulled, and yet the guidance was a long time coming, probably way overdue. And companies were doing a lot of work to include diverse patient populations in their trials anyway, even without that guidance. And so I don't know how you would not continue down that road. And again, I think it almost goes back to what I said before is, you know, depending on how FDA wants the data sliced and diced, you can submit or resubmit. I don't know what happens if FDA comes back and says you're going to be in some way punished or penalized because you did it. I can't imagine that, but I think we don't know that for sure.
I think another note too is that the diversity action plans are still part of, you know, the law or codified into the FDA code. So that piece is still required for a clinical trial, despite the fact that the guidance has been removed and put back and removed and put back. So, you know, so you still like they still have to they should still follow that. I would imagine that guidance or that, you know, code from the FDA.
And we know that laws trump executive orders. No pun intended with the word Trump, but laws win. So it's a good point.
Becky, we come in with our team that Becky worked for years on the payer side, and we always say payers are people too, right? As we've learned to know. I know a lot of our work is kind of pushing the dial with that. You raised some really interesting points when we were talking about this this webinar and the topic of how important this was to you when you were on the commercial side and your clinical review of products. And I just didn't appreciate that as much. You know, I'm thinking about the payers more looking at, yeah, maybe the unmet need or the burden of disease and the population using the drug, but it sounds like it's much more of a thought and an issue than I ever considered or really appreciated. Can you talk a little bit to that about your experience before and how this evolved for you over time, or where you think people need to remember that the commercial side is kind of living in this space?
Yeah, so I think just to add on, so I had mentioned, right, that the plan sponsors, of course, have increased interest in this area too. But the organization that I came from was very focused on health equity and putting out specific policies, different plan designs, making different plan designs available too. And then really trying to target areas that you know, they felt could be particularly impactful from all of these different programs. So when I worked at the payer, I was you know, there were very active health equity councils and work groups that were looking at kind of everything top to bottom within the payer, from the networks, making sure that, you know, networks were diverse and that information was available for beneficiaries to review, making sure that there weren't unintended consequences with plan design that could potentially lead to barriers to access, as well as challenges with cost. And then the different programs and services too, like how could those be, improved or changed in order to have more of a direct impact for, on health disparities and improving health equity.
Okay. Lots of questions coming. Okay, so I'm just going to read this one to make sure I ask it correctly and kind of check it out. One question just for you guys from the hospital perspective. How are hospitals approaching? I know hospitals work with manufacturers on, mammogram buses and different services that they can bring and manufacturers can bring into the industry. What should the hospital community be doing in this situation?
I think if they're interested in, still getting this data or, tracking and measuring those, partnerships within the community are critical for, capturing that data and capturing how those services are impacting, their potential patients or members of their community.
Yeah, I agree. I think they're like they're really in the community, right? And they're actively participating in the care, and they're seeing the potential downstream impacts of, if programs are removed that have been really impactful to their patients and to their community at large. So I think just the continued advocacy on behalf of hospitals, again, providing that data, whether it be a published paper or some sort of press release or information describing how these different initiatives have had that impact within their community.
Okay, so we just had a question come in. I think I can take a first stab at it and then let you guys add to it if there's anything, or you ladies. So this mentioned, so in the 2024 election, we did see a significant shift it said racial and ethnic, I'm just gonna read the question, significant shift from racial and ethnic groups to the GOP, and some individuals in these groups see themselves as part of an economic class rather than a racial or ethnic class. And we also saw a continued shift in rural populations voting for the GOP. So how do these shifts change our research into racial minorities? And could this present a possible way to realign our messaging in economic and rural terms? My first answer is I would say the focus on SDOH has become a big factor there. So for example, we have a huge SDOH database here that we use for a lot of our economic studies. And the questions in it go beyond, your typical, like, where do you live? How do you identify in terms of race? They're going into things like, what is your credit score? Because, you can have people who make a lot of money with terrible credit, right? And they may have crazy medical debt or things that would hinder their ability to pay for services, or how many people are living in your household, educational status, what people are making in terms of household income, individual income. You're looking at that at a much deeper level. Food insecurity, some of those types of questions that you can ask that I think do this, right? And that's where, earlier in the conversation we talked about, and someone asked about, like, do we need to change the term? I personally have always liked talking about SDOH just as much. I live in Georgia. I live an hour north of Atlanta, and I'm kind of on that exurb where it becomes very rural. And I see a lot of very similar health challenges to people in that area that I also see in inner cities. And I think thinking about it from a socioeconomic perspective and changing that tone does align that. And I would hope that even if DEI has been an inflammatory tone or word to a lot of people, or a politically charged thing, I would hope that SDOH continues to be something that researchers can focus on, because I think that is the alignment that's necessary there. Any other comments on that one?
I think just a comment regarding like the rural piece that I can make, like there's other initiatives that payers have that are focused on, rural settings and how to provide access to care, whether it be through telehealth, providers, increasing the abilities of pharmacies, especially independent pharmacies that may be more prevalent in rural settings, to provide clinical services to patients as well. So to Amanda's point, it's bigger. SDOH is, includes a lot of other things that, can be very impactful in improving health for those rural communities.
Thank you. All right, well, that seems to be the questions that have come in, and we appreciate the insights and deep thoughts from people. I think this is one of the most paid attention to elections and first 90 days that we'll probably see in a long time in terms of a change in administration. We will end with closing thoughts. I'm going to ask you each to look into your crystal ball about something, but I would like to highlight our next month's, and I think this is a really interesting topic that also goes into access and what we're affecting and thinking about at the state level is now we're seeing states establish prescription drug affordability boards where they're using metrics to essentially set a state pricing limit for a medication. And, we're not like in it yet where everyone's doing it. They're all developing their methodologies and thinking through how to design their PDAB, what metrics to use to set the price, and then what that's going to do in terms of affecting the Medicaid population in that state. Could this be something that all of a sudden, these are published prices, we've got drug price negotiation and everything's going to get affected, and we're just going to see a mass reduction in reimbursement for innovative treatments. So this is a really, really, really hot topic right now. I would say, of the 10 things that we're hearing our clients freaking out about, recently, this is one of them, definitely. And we do have a issue brief on our website that we just put up on this issue as well around how ICER could be used for this and some of the issues and concerns around that if ICER evaluations were used by state levels. So that's the next one. I will just leave you all with a crystal ball question. Do you expect with FDA PDUFA dates and everything, do you think with some of these changes and the data that's available in the staffing, at the end of the day, where do you see pharma really having to focus their efforts in this issue in the next year? So should they be trying to get the data up? Should they be trying to get new data resources? Do they think it's all going to come back? And they're expecting this to be a big push that the administration will have to eventually lean in on and put the data back out there. Do you think FDA, you'll see a change now that we have a new head of HHS? Like, what do you think is going to be the outcome of all of this in the next year or two? I'll start with you, Jessica. Do you think it's coming back, or we have to reinvent the wheel, or what do you think we're going to do?
Okay, well, notoriously, I'm terrible at predictions, so please take this with a grain of salt. But I've been thinking about it a little bit, especially with one of the earlier questions we got about, like is a different term necessary? And I think potentially reframing some of these issues under the Make America Healthy Again framework, because the goal is to make people healthy. And we know that there are health disparities. So if we can figure out a way to perhaps reframe it to be a little bit more palatable to the administration, then I think it's less about going away and more about a reframe is my hope.
Great. And you just heard that you want Jessica on your fantasy football league because she's a terrible predictor. So she may be your fantasy football. Please send her an email. Her email is on our website. Okay,
12 plays 3 years in a row.
Oh yeah. Hey, Becky.
Yeah, I mean, I think I'm with Jessica in terms of it. It's hard to make a lot of predictions, but I agree with, I think, a focus on just education of our just, new administration, anybody that's in, a legislative capacity, just to help them really understand the potential impacts downstream of removing this type of information. We're going to lose the ability to identify populations at risk, track disparities. And this can, not only lead to poor health outcomes, but again, a pretty significant impact to costs overall. So I think that I agree with the reframing, but I think also just this education piece will be really important to help people understand how this all translates.
Okay, thanks. And Tracy?
So because the other ladies have done, I think, a pretty good job of saying what I would say is maybe gonna happen. I want to talk about what happens to PDUFA, right? Because RFK has said in the past that he thinks the FDA should be solely government funded. And yet we know that they're going to be cutting people, I think, mid-March. They've already cut large groups within the device approval. And some of those people were PDUFA hires. And so that means at some point that money should come back to the manufacturers that are paying to have those enhanced review times. And so I don't know how long FDA can actually meet the timelines that have become the norm without PDUFA funding and without a full complement of even government paid employees. I mean, PDUFA is like 45% of the FDA budget or something like that. So I think PDUFA and the FDA are this is definitely a space to watch, not, for the obvious reasons that approval is the lifeblood of the industry, but because significant changes could be coming.
Great. Thank you, Tracy. All right. Well, we will check back in and see if we are right. But appreciate everyone's time. Thank you all so much for joining us. And if you have any follow-up questions, don't hesitate to reach out, and we'll have all of this posted on our website soon. Have a great day. See you next month.
Thank you.